you, Shelley. Welcome, support group leaders from across North America. I'm Lisa Wise, chair of the IWMF support group, and I'm thrilled that you're joining us today. Huge thanks to Michelle Posick, the IWMF Manager of Information and Support, who is a truly invaluable resource and partner in crime. What an absolute honor to extend my warmest welcome to the legendary Dr. Morie Gertz, a beloved international WM guru. Dr. Gertz, as you know well, is a hematologist oncologist and chair of general internal medicine at the world-renowned Mayo Clinic in Rochester, Minnesota. His peerless expertise, vast experience, sharp wit, and huge heart are well known and loved, and he needs no introduction here on planet WM because he puts the rock star in our rock star meetings. So I know that in this group, we have a whole lot of Dr. Gertz groupies and Walden fans. And I was going to do a Dr. Gertz trivia contest to start, but I didn't want to embarrass him. So I'll just tell you the answer to the bonus round was going to be, he won Resident of the Year 2 years in a row. So for all of you that were wondering, it was 2 years in a row. Resident of the Year, that's pretty impressive. Dr. Gertz, I hope you're laughing. Seriously, we are all in for a very big treat from Dr. Gertz. I go to the Ed Forum for the world-class WM knowledge, but the reason that I stay is for his first-class jokes. He never disappoints at a microphone. And his cold hard truth about white sugar was a spiel that literally changed my life. So lastly, when I speak every week with WMers in my role as a Lifeline volunteer, they call and they are newly diagnosed or they're beginning treatment, and often they need help. I send them, after we chat, I send them a welcome letter that's full of rich resources that will help them find their way in that critical moment when they are newbies. And I always include a link to the classic garden talk every single time, which has helped countless WMers find their way out of the weeds. I'm wearing my garden top today in honor of Dr. Gertz. Welcome, doctor. Thank you for taking the time on your busy Friday morning to be here. We are so very grateful. I will now mute myself so we can hear your introductory remarks, and then I'll pass back on for fun questions.
Thanks for the kind introduction. I hope everyone can hear me okay. My volume's okay. All right. I just want to do a little bit about the numbers and then what I'm seeing currently as kind of the missed opportunities in the practice and the unmet need. So given the current statistics, we're probably looking at approximately 3,000 patients newly diagnosed with active, not smoldering and not IgM Muggis, Waldenstrom every year. And because of the really dramatic advances that are leading to unbelievably good outcomes, there are probably between 40 and 50,000 Waldenstrom macroglobulinemia patients alive in the United States at this time. Now, if you look at the membership of the American Society of Clinical Oncology, there are about 40,000 members. So if you do the math, the average oncologist will have, on average, one patient with Waldenstrom macroglobulinemia in their practice. And therefore, they're going to lack experience. And therefore, they're going to be getting their experience from reading up to date or the latest book chapter in the oncology journals or looking at MSMART, that sort of thing. And quite frankly, if it was my family member and I was the only individual in the practice, I quite frankly would not be comfortable with major decisions being made by an individual that really lacks experience. I suspect that in most training programs, most medical oncologists haven't seen a single patient with overt macroglobulinemia that they can follow. And in residency training or oncology training, which is 3 years of monitoring a patient with Waldenstrom is nothing because the course is 10 to 25 years. And so I don't think they get really just to get that feel, to get that real experience, that internal knowledge. And in my practice, I'm seeing really two issues. Again, if we do the numbers and we say that there's 40,000 to 50,000 people, 3,000 newly diagnosed every year, and we look at how many IgM MGUS there is out there. Well, at age 70, about 3% of adults will have a monoclonal gammopathy. 1 in 6 monoclonal gammopathies are IgM. Therefore, if you just did broad routine screening of the population, one person age 70 or older, 1 in 200 are going to have an IgM protein, 1/6 of 3%. And so that's 1 in 200. Rochester, Minnesota, we have 100,000 people. We have 20,000 over the age of 70. And so we have essentially 100 people with IgM monoclonal gammopathies. So the number of IgM monoclonal gammopathies vastly outnumbers the number of Waldenstrom's patients. And what I'm seeing, at least in my referral practice, is medical oncologists who are initiating therapy in completely asymptomatic patients based on misinterpretation of symptoms. I'm dizzy. I'm lightheaded. I have a headache. Oh, you probably have hyperviscosity syndrome. You need immediate therapy. Or a CT scan is performed and it shows tiny little lymph nodes, widespread, but tiny little lymph nodes under the arms or in the neck or in the abdomen, and say, oh, you need treatment, when those patients have probably had those lymph nodes for 5 to 10 years. And so I see a lot of concern, and I don't know if that's a concern, that there may be consequences if you miscall and delay treatment, because in a lot of medical practices, the way it's viewed, it's easier to do something than it is to do nothing. And it actually takes a bit more experience and self-assurance to say do nothing than do something. And I'm seeing oncologists telling patients, well, we can observe you now, but when your IgM goes over 3,000 or 4,000 or 5,000 or some ridiculous arbitrary threshold, therapy is initiated in otherwise asymptomatic patients, which I think is not a very good call to just go by the numbers without actually talking to the patient and asking how they're doing, how they're feeling. Do they know anything's going on? So this when to treat, I think, is a really important role that I think support group leaders can provide their members where they're on the cusp of initiating therapy, about seeing a center of excellence that might be able to provide guidance for the local oncologist. The second thing has to do with this ability to keep moving the field forward and developing new effective therapies for macroglobulinemia. And for that, I mean participation in clinical trials. My experience has been that only a very small fraction of macroglobulinemia patients are on active clinical trials, and through no fault of their own. What ends up happening is they see their medical oncologist, they legitimately need therapy, no question about that. And then the medical oncologist says, okay, here's how we're going to treat you. And the patient says, okay, let's go, without asking what are the alternatives, the pros and cons of the various therapies. And am I eligible? And this is the big thing about getting in on the ground floor of the next cutting edge therapy. And, you know, all of the treatments that we currently are actively using were developed as clinical trials. I mean, the first patients to receive ibrutinib, the first patients to receive zanubrutinib did so in the context of participating in clinical trials, and presumably had spectacular results because they were willing to be considered. And now we have clinical trials that are combining ibrutinib with ixazomib, for example, or PD-L1 inhibitors are now being explored in macroglobulinemia, and combination therapies with venetoclax and combination therapies with venetoclax and ibrutinib and other BTK inhibitors are being explored. And in order to help the entire Waldenstrom population, we need to develop these and enroll these. So it's a plea, because a lot of these trials are nationwide trials in cooperative groups, that when you're counseling your members about either initial therapy or second or third line therapy, to give consideration about getting involved in trials. And I think it's important to explain, because some of the feedback I've gotten is this whole guinea pig business, when in reality, what's going on is that global thought leaders are putting their heads together. The smartest of the smartest macroglobulinemia experts put their heads together to say, what do we think would be the next big thing in macroglobulinemia? So these aren't combination treatments picked at random, but these are regimens that are really developed by consensus by the people who really understand the biology of the disease and are looking to provide cutting edge treatments that will improve outcomes and make these famous people even more famous as they go forward, developing the next new treatment. And so group leaders really serve as mentors and counselors to patients. And I think this issue of when is the time to pull the trigger for therapy is poorly understood in the community. And the remarkable benefits of entering a trial of therapy that's been developed by some of the best is, I think, lost on some of these individuals. And you can play an important role in encouraging patients to just look at the entire breadth of options that they have available. So that's kind of the introductory remarks that I wanted to make. And I'm happy to spend the rest of the time discussing the questions that you believe are most important to you.
Dr. Gertz, thank you so much. That was really, really helpful, because every single box that you see here has a support group leader in a different state or province all across the US and Canada. And you have to imagine thousands of people behind all of these 38 faces or so, because they're representing the support groups that rely on them, and giving over those messages are critical. The clinical participation, and then I love what you said about doing nothing is harder in some ways than doing something, because when I speak with newly diagnosed, one of the toughest things for them, or not necessarily them, but their family members, is the idea of sitting and waiting. And they feel that in some ways the disease wins when they're not throwing the first punch, so to speak. So kind of turning around that, understand that language in their head. Sorry, go for it.
No, so let's provide some context there, because I think it's a legitimate consideration. And so when you're looking at the media and the community and the press, the message is get the diagnosis early, treat it aggressively, and don't delay. And when a macroglobulinemia patient sees me, they get the exact opposite message. And the question is, why is there a disconnect then about early intervention versus simple observation? So let's talk about that. So let's say I see a patient who has a routine mammogram, and the mammogram clearly shows a malignant nodule in the breast. And that patient didn't know about it, and that patient was asymptomatic. Am I going to tell that patient, oh, you have no symptoms, don't do anything, go home, we'll repeat a mammogram in 6 months? And you know that's not what happens. And the same thing would happen if I saw a smoker who had a lung nodule, no cough, no shortness of breath. I wouldn't say, oh, yeah, that's not bothering you, we'll recheck a CT chest in 6 months. We would immediately act. What's the difference? Well, the blunt answer is, in the scenario of the breast or the lung, early treatment will cure. I can't say the same for macroglobulinemia. I can't cure it. Well, if you can't cure it, like you can breast and lung, which would mean instant intervention and aggressive intervention, because you can cure with early intervention, the same cannot be said about macroglobulinemia. Well, if you can't cure it, then what's the goal of therapy? Well, the goal of therapy is to obviously prolong one's life and to eliminate symptoms that impact on quality of life. So let's dissect that down. First of all, early treatment at the mucus stage or the smoldering stage absolutely will not prolong survival, because it's not a question of how much. The IgM's 2,000 or 4,000 or 6,000, that doesn't impact outcomes. If you look at all the studies, things that predict outcome have nothing to do with the level of the IgM. IgM is never predictive. Why is that? Well, let's look at infection. You have a urine infection or a blood infection. Physicians don't ask, well, how much infection is there? How much is it? What is the level of the bacteria? Nobody cares. The only question is, do I have the right antibiotic that the disease is sensitive to? That I pick the one that's going to kill all the bad bacteria, not how much bacteria there is. That's pretty comparable to macroglobulinemia. How much is not relevant. Getting the right treatment, right combination is relevant. If you have a very sensitive clone and effective therapy, it actually doesn't matter how much there is, you're going to respond because it's going to kill all the disease. So that's for survival, why early intervention at the MGUS stage doesn't make any difference. The second issue is symptoms. Palliation of symptoms is important. To tell a person who's losing weight, not eating, profoundly fatigued, can't walk a city block, to say, well, we're just going to keep observing you, that's crazy. And I've actually seen patients for second opinion who come to see me and they've been getting blood transfusions for 6 months. And the doctor's saying, yeah, well, we'll continue observing. And I'm like, yeah, I'm real sorry here. That to me is symptoms. But if you have no symptoms at all, I mean, you're really feeling great. You didn't actually know you even had a problem. Doctor found the protein and say, wow, you've got this. And the patient says, oh, I'm so surprised. I can tell you that if I treat you and you're already asymptomatic, whatever I treat you with, you're going to feel worse. I will guarantee that, because there's no treatment that I have that's actually going to have no symptoms, no toxicities, no side effects at all. So if you're feeling great and early intervention doesn't make you live longer, then I don't understand what that goal is. If you're feeling great, I promise when I treat you, you're not going to feel great. I guarantee it. And so I think we're going to delay treatment until you're not feeling great. But the real crux here, the real crux about sitting on this is the lack of curability. And for some people, it's actually, they can't be reassured, and they can't, I mean, they have so much anxiety, they will insist on therapy. And when that happens, I mean, if the patient can't function because they say, I've got this blood cancer and nobody's doing anything about it, you can treat that just to bring their quality of life back to normal. But I warn you, and this would go back, I'm telling you a story 25 years ago with different treatments, where I treated an individual who really insisted, just couldn't function with observation. And about 6 or 7 years after treatment, got a second cancer related to the treatment. So that was really a horrible outcome that I feel really, really bad about. But it's this kind of story about all the treatments have side effects. And if you're feeling good, you may want to just trust the recommendation to sit tight.
Which leads perfectly to your point about getting a WM expert opinion from a center of excellence to help guide, because that's who will know when the right moment is to do to follow Dr. Waldenstrom's advice, do as little as you can for as long as you can. And it's only an expert like yourself who will know when that moment is right.
Right. I think in the United States, there may also be other concerns that if you're really inexperienced and I tell a person that I'm going to watch them and then something bad happens, maybe I'm liable. But if I kick in right now and do something, which will certainly work, and I'll say, look, everything's better. Your IgM, which wasn't important to begin with, went way down. Hooray. And everybody's quote happy. I don't know how often that happens, but I suspect that is a small player in the back of one's mind if you really don't know what to expect with the natural history of this disorder.
Wow. Okay. I hadn't thought about the liability piece, so that's really new. Dr. Gertz, what do we think about getting to some of the pre-submitted questions? Shall we do it?
We should do it.
Okay, awesome. So I think we're, if it's possible, we at the beginning of the call, people were chatting about COVID and the Washington Post article and CDC leakage and some interesting things that are happening. So if we could start with our COVID questions first, I've got 6 of those, and then I've got about 8 regular treatment questions. And I think in the next under an hour, we can probably do that together so that we can get you off to the rest of your day with lots of gratitude. So the first question is, what do we know about WM patients' ability to develop immunity to COVID as a result of the vaccine? It's the $1 million question, and
sure,
it's on every WMer's mind. So I thought.
So here's the rough numbers. So you take a normal adult and you vaccinate them, and the antibody response rate's about 99.6%. If you look, the myeloma population has been better studied, but the results should be translatable. High antibody titers are achieved in 80%. And so in patients who've been vaccinated, I've actually been checking them for antibody titers. And I've been really quite pleased that over 80% actually are showing positive antibody titers, so they're immune. Now in the myeloma space, the development of antibodies appear to be impaired by the use of the antibody Darzalex. And I'm quite concerned that exposure to rituximab is going to impair the antibody response because, of course, it's attacking immunoglobulin secreting B cells, the CD20 positive lymphocytes, the white cells that are the underpinning cells of macroglobulinemia. Those are also responsible for antibody responses. And so particularly in patients who are actively receiving rituximab treatment, I think that there are concerns about antibody. And if I have vaccinated patients, I'm getting pretty liberal with their ability to be out and about pending what's going to happen with Delta. But patients who don't have antibody, I think they need to be quite concerned and need to maintain masking, distance, and disinfection. But it's pretty easy to measure antibodies. I mean, we get same day results, and then at least we know exactly what level of caution, although I still am telling people, even if they're vaccinated, they really need to avoid social situations with unvaccinated adults. That's, I think, a ticket for problems.
So maybe we want to drill down on that a little bit. When you say social events, are you saying indoor? I don't know whether you want to do this, Dr. Gertz, or not, and I wasn't planning on it, but do you want to define social events, be it indoor or outdoor, be it large versus a controlled number of people?
Outdoor, if you can maintain 6 feet, then I don't see a problem with that. I don't think that outdoor Lollapalooza in Chicago is going to be any different than indoor, But if you're going to a backyard wedding, 40 people, and you can keep yourself relatively distanced, or you're going to an event with a dozen people and you know that they've all been vaccinated, I would look at that as a pretty low risk situation. But if you're showing up to crowds, this week is the Olmsted County Fair, I think that's dangerous. That would really have me concerned. And I mean, it doesn't mean you can't go, but you really need to maintain your distance and you've got to be masked no matter what people look at you. And going to the grocery store, I think you still have to maintain mask because figure nationally, a third of the patients still aren't vaccinated. 100 million people are unvaccinated and they're reservoirs to make you sick. And so I think that, it's really a question of ability to distance. And the real difference between indoor and outdoor, it's artificial. Just indoor, how are you going to keep 6 feet away? Outdoor, I know how to do that, or I'll leave. But indoor, that's really, really challenging.
Right. Okay, that's really helpful because a lot of us, there's a lot of chatter now online where people are IWF Connect and on Facebook where people are really talking about how much is too much, how close is too close. And, you want to get back for mental health reasons, people want to be able to reconnect. But then again, with this variant and with knowing our immunity issues, we want to do the right thing. So what's the significance of a WM person showing no antibodies following the COVID vaccine or showing some antibodies in relation to what you just said about those helpful guidelines? Like, should we be thinking about, well, I have a little bit of immunity or I have zero immunity? Does that in any way impact behavior?
I don't know that we have information to suggest that the quantitative antibody titer is predictive. I think we simply, for me right now, with the information we have at hand, it's binary. You have some immunity, you don't have immunity. We already know that, at least from the broad population, any immunity at all results in pretty dramatic attenuation. I mean, what you're hearing and what we're hearing is that people with antibodies are getting infected, but they're not getting hospitalized. It's a big distinction. You have in some media saying, well, people getting the vaccine are getting infected. What's the point? Well, that's crazy because they're not really dissecting it down to distinguish infection from being sick. And in the hospitalized, in the Mayo hospitalized population, the fraction of hospitalized patients who are vaccinated is 1%. Only 1 in 100 people hospitalized is vaccinated. So essentially, you still can get infected and maybe you'll get sick, but you're not going to end up in the hospital. And that for me is kind of an important distinction.
What an incredible statistic. Wow. Thank you for sharing that. What are your views about the possibility of a booster vaccine shots for WM folks specifically, short of getting on a plane and going to Israel where they're already offering the third booster? Any thought, and do you want to take out your crystal ball and tell us what the next few months might hold?
Well, it is the crystal ball, but I look at Israel as a Western nation, and they have declared that patients over 60, not every patient, but patients over 60 will be receiving a third Pfizer vaccine. And if you look at the antibody titers of patients over 65, Pfizer said that if you get 2 doses, your immunity is 99%, but at 6 months, it's 86%. So the immunity levels start to fall off. I don't know why that should surprise anybody. You have to get a flu shot every year. You have to get a tetanus booster every 10 years. So there are some immunities that are lifelong, like shingles or pneumonia. And there are those where the ability to sustain antibodies declines with time. And it appears, at least in the over 65 population, at least to the Pfizer immunization, COVID immunity begins to fall. And I would think personally that if there was a 14% chance of getting infected, I'd want a booster. And I think Israel in this one's going to be a leader. It's going to be hard to ignore. And the questions are going to go to CDC and FDA saying, why is it right in Israel and not right in the United States? And I think those will mount. And I suspect that the current recommendations, which I am abiding by, no one's getting a third immunization from me, but I think that will likely change. And we certainly have the number of vaccine doses and administration capacity to follow through.
Okay, fascinating. So I want to continue that thread, pull that thread a little bit with, let's say somebody got 2 Pfizer vaccines, showed no immunity. Do you think, again, taking out the crystal ball, do you think that a booster might be recommended? And if so, do you think they'll be going with a different manufacturer, or what are your thoughts on, what, like, it's almost playing roulette here.
Right. So I do want to preface that I think it's purely speculative. You could argue that after 2 doses and no result, excuse me for just a moment. Sorry.
No problem. Please take your time.
No problem. So after 2 doses, it raises a question: why would you give a 3rd dose of the same vaccine, but you try for a different, either a different messenger RNA with Moderna, or look at a immunization against spike protein with J&J and change? But right now, we actually don't have authorization. It wouldn't be considered appropriate medical practice to proceed, but I suspect those recommendations likely will eventually follow.
Thank you so much. And thank you for clarifying that we're looking in our crystal ball now. We're not actually recommending anything. So I appreciate that. This is a very interesting question. Do COVID-19 vaccines increase IgM? And if so, should I be concerned that a shot would make my WM worse?
So that's pretty easy. First of all, no one's measuring the primary immune response or the IgM immune response. The antibody response that we're always measuring is IgG. But having said that, an immune response, the primary immune response, would not come from the monoclonal Waldenstrom population. It would come from residual polyclonal B cells that are capable of producing polyclonal IgM. So there's no way I can think through a mechanism by which immunization would aggravate Waldenstrom. And this business about immune response to vaccines wouldn't be a COVID specific question. You'd be asking the question, will the flu shot make my Waldenstroms better? Will the shingle shot make my Waldenstroms worse? Will pneumonia vaccine? Will diphtheria, tetanus? I mean, if you're talking about immune stimulants, will that aggravate my Waldenstroms? And we'll go beyond vaccines. If I catch a cold and I mount an immune response, if I cut my hand and it gets infected and it's immune response, all of those are immune stimulants, of which we're having a lot more often than immunizations. And there's no evidence that that is aggravating the WM.
I want to make that the little blurb, Shelley, if we could do a 30-second thing when we do when we send the link out so that everybody can just see Dr. Gertz saying that, and then watch the whole thing. It's like, okay. Why, this is an interesting one. Why is the CDC not including natural immunity with vaccinated immunity to have it all add up to herd immunity? So it's a herd immunity question here, and what's being counted or not counted towards the herd.
Well, look, right now, we've had 6 million cases of COVID in the United States. So that's about 2% of the population, or 1 in 500, or 0.2%. Herd immunity is 80%. So count it if you want, but who cares? It isn't going to increase the numbers at all. I suspect that natural immunity patients have some immunity, although I have no idea if you got infected with the primary thing, that you have immunity to Delta, just so we're, just as another example, there are 3 serotypes of polio. And if you got polio, you're immune to one of the 3. You could still get infected to the other 2, and you still need vaccination.
Wow, I didn't know that. Okay, fascinating. One last question, and then we'll move on to some treatment questions, if that's okay with you. What are the chances of shedding of spike proteins from vaccinated people? So, for me, it's like, that's the how close is too close question. There's folks who are vaccinated, it's the hug question. When they go out into the world and I'm keeping myself, partially locked down, how close is too close? Could they, transmit something to me unknowingly?
Shedding spike protein is not the same thing, of course, as shedding live virus. That's number one. But I think we have to operate on the principle that if you've been fully vaccinated, there's an 80% likelihood that you're immune. But yeah, it's 20% that you don't have antibodies. And yes, if the person is unvaccinated, it's not clear that that vaccinated people are transmitting live virus as opposed to spike protein. That's important. So you take an immunized people, you do in a swab, the swab is positive, that we've detected spike protein, not the same thing as carrying live virus, but the actual isn't known.
Okay, sorry, I was thinking about that a little bit. That's okay. I promised we were going to move on to treatment. I wanted to ask a follow-up question there, but let's keep moving. Dr. Gertz, all fascinating. Thank you. Any new treatments on the horizon that are most exciting for you personally? What do you think looks especially promising?
Well, I think the last two agents that I think are going to be beneficial are both zanubrutinib and venetoclax. I think there are still another, generation of new agents that are on their way. But I think for right now, what's available, those two to me are really impressive, both in terms of response depth and tolerability.
Exactly. Okay. So now those are the new school. Let me take it back old school for a second and ask you, we know that Velcade causes peripheral neuropathy more frequently than other medications. Which symptom clusters still require treatment with Velcade, and are there any other alternatives? I'm surprised how many WMers I speak to who, I still see, hear Velcade in the mix.
I don't use it first line ever. It's just not a choice for me because I am so worried about the neurotoxicity. Depending on who you're talking to, the nerve damage from Velcade can really be quite profound, where people have intense pain and it interferes with their sleep, and they have to take sleeping medicines or they have to take nerve blocking agents, and sometimes they have to take opioids. I think that's completely crazy for a disorder that's going to run 10, 15 or more years to have painful neuropathy 4 months into treatment, and then you're just going to have to live with it. So frankly, there's no question, Velcade, highly active, high response rates, but I think that most oncologists and most oncology treatment nurses aren't monitoring adequately for neuropathy, so that once someone says my toes are numb, the response is, we're done with treatment. We're shutting it down. We're not going to do any more therapy with that drug. And they just say, oh, that doesn't sound very bad. We're just going to see how it goes. And so I don't think that Velcade, despite the fact that it's highly effective, is a good choice, because the neurotoxicity in the Waldenstrom's population is much higher than any other lymphoma or myeloma population. And I think that oncologists use it because they're really familiar with it from using it in other forms of lymphoma like mantle cell lymphoma or multiple myeloma. So they have experience and comfort with it. I just think it's too toxic for the Waldenstrom's population. And although it's effective, I don't like using it because of the specific toxicity you mentioned.
Okay, thank you for your clarity on that point. We actually have one of our newest support groups is a peripheral neuropathy support group, and we have several support group leaders, some who are on this call right now, who lead that group, and there's 4 meetings happening with a ton of interest. So this is a really critical piece, and thank you so much for speaking so clearly about that. I have several BTK inhibitors. Okay to keep going? Do you need a stretch break or a back?
I'm good. Yeah.
You're good. A water break. Okay. So when a BTK inhibitor stops working for a WM patient, this is a question that is getting a lot of chatter in the community. When a BTK inhibitor stops working for a WM patient, can a different BTK inhibitor be introduced and be effective?
That isn't known, but I'd be skeptical, and it wouldn't be my first go-to. I think if you fail a BTK inhibitor, then there's probably been some mutations that probably affect the class. And the differences between the BTK inhibitors are not on response rate. They're all about the same response rate, and their mechanism of inhibition is not dramatically different. I think the choices between the BTK inhibitors is really driven based on tolerability and side effects. And personally, based on what we know today, given the fact that I have so many options for the treatment of macro, that if I had a patient who was clearly failing a BTK inhibitor, I wouldn't be looking for an alternate BTK. I'd be changing classes.
Okay, interesting. Okay. I have two Imbruvica questions. Thank you for that explanation. Should a patient's blood saturation level per body weight be measured and factored into the determination of dosage for Imbruvica? So there's a lot of talk about people, what I call like customizing, their Imbruvica experience. It becomes this kind of, so each person finding that sweet spot of how much they need, what do you think about saturation?
I don't think that saturation has a good clinical correlation with disease control. I'll tell you how I generally manage this though. For most patients, I'll give people standard 540 milligrams, but then I'll assess how they're doing. Now, if they're responsive and I can see the response and they're not having side effects, then I don't really think there's really much to discuss. You're doing okay, you're feeling okay, you're responding, don't rock the boat. And of course, if you're not responding, that answers the question as well, as forget that because this is just not the right drug for you. But then the question comes up, what about someone who's clearly evidenced the response and they're 3 months into it, but they're having the fatigue or the achiness or the easy bruising, and they're just not feeling up to snuff? I think it's quite reasonable at that point to consider making a dose reduction, 540 to 360. And then at that 360 dose, looking to see if that sustains the control of the IgM monoclonal protein. And so I think the first job is to establish control of the disease and prove benefit. But if after benefit has been achieved, the disease has plateaued, if there are side effects, I think it's completely fair to start weaning down to see if that benefits side effects. But those decisions are clinical decisions, not based on in vitro, in the test tube measurements of drug saturation.
Okay, thank you very much for that. Very helpful. Do you think that all patients on Imbruvica should be tested for MYD88? If someone is on Imbruvica and has never been tested for that, should they be?
So there's a couple issues there. That first of all, in a newly diagnosed patient, I must say I do MYD88 testing. I think it's both helpful, both just to reconfirm the diagnosis, as well as give some insights what to plan. But let's look at it this way. Let's say you're on ibrutinib and you're on it because it's working. What are you going to do with the MYD88? If you're MYD88 negative and you're on it and it's working, are we stopping it now? It's working. I mean, that's number one. Number two, for most patients, getting a reliable MYD88 is a bone marrow exam, not a blood test. So you have to subject yourself to another bone marrow when there's no other clinical indication, because by definition, you must be doing well. Otherwise, why would you be on it? And third, if your response is substantial and the number of Waldenstrom cells are low, MYD88 assay may be uninformative because there are insufficient numbers of Waldenstrom cells to actually do the assay. I mean, you can't get an MYD8. Remember, MYD88 doesn't come from the marrow. It comes only from the Waldenstrom cells in the marrow. And if you do the test when the number of Waldenstrom cells are low, let's say 5%, you may get a negative result, but it's not really negative. It's uninformative because you have insufficient clonal cells to do the assay. So all of those things are issues. And if you are on treatment and you didn't have an MYD88, I would say if you had seen a center of excellence, you'd know your MYD88.
Okay, excellent. I'm glad you brought that back to the center of excellence. And thank you for explaining to me where MYD88 comes from, because I did not
Yeah, it's
appreciate
not
that
the white
nuance.
cells or the red cells. It's only the Waldenstrom cells. That's why, you know, I would expect MYD88 to be positive in 100% of IgM MGUS. But the problem is so many MGUS patients have only very small numbers of cells, so you don't get a positive result. That doesn't mean it's not positive. That would be considered an uninformative assay.
Okay, excellent. The next question is about language, and it's an important one, I think, because as support group leaders, we get a lot of questions about where am I in my disease process? So this is the question. And all of these questions are so excellent. I just have to give a shout out to all of the support group leaders in front of you who ask these amazing questions. They're just, I'm really enjoying them, everybody. So I wanted to thank you all for that. And I'm enjoying your responses as well, Dr. Gertz, not to take the spotlight off. If all blood work is within normal limits for over 6 years, this person is asking, can we say that WM is in remission? When can we use the word cured? We hear the word intermission being used, meaning we're always between treatment because this doesn't get cured. But a lot of patients, especially newly diagnosed or who have seen some improvement, are wanting to rush to remission language. Help us out, please.
So that's really very important. We'll start with the first. When can you say you're cured? Never. You can never say you're cured, period. People will recur at 20 years with this disease. In my practice, I never use the term remission, ever. I talk about response and response depth. And if you look at the way the professionals are talking to each other, they're talking about minor response, very good partial response, and complete response. So we don't talk about remission, we talk about response. And so, I'm sorry about people who want to say they're in remission, but they may just have to say, I'm doing great. I feel great. And I'm really optimistic. The future is bright, because it is. And if you want to talk about what your depth of response is, we can talk about that. But also, it's important to remember that if you look at patients who have a minor response and people who have an objective response, survival between the two is the same. So depth of response in Waldenstrom's doesn't even predict outcomes like that. I think it's great if you could say all my blood tests are normal. I think that's really good. But I think that if you're trying to use the word remission, once again, you're trying to compare Waldenstrom's to breast cancer or colon cancer. And I'm real sorry, you can't. Those are different diseases. There's this business, as you all know, with certain cancers, that if you're in a complete response for 5 years, those are considered functional cure. You don't want to do that with Waldenstrom's. You don't want to tell someone who's 5 years or 10 years, it's all great. And the same thing with MGUS. I've had physicians tell patients, well, we've been following your IgM protein for 10 years. It hasn't changed. It's enough already. That's a mistake. Yeah. This disease has a constant risk of transformation, and you have to continue monitoring lifelong. And once you've been diagnosed with Waldenstrom's, let me rephrase this. If you're cured, then you don't ever have to go back to your oncologist. And when that's happening, forget it. You will need lifelong monitoring. There's just no escaping it.
Yeah. Very sobering, but very eye-opening. And thank you for giving us the cold, hard truth in that, so that we can help folks in our support groups understand that reality, so that they can understand it's a chronic disease, that it's going to be with them for life. And
well, Lisa, isn't high blood pressure the same thing? Well, when am I cured of my high blood pressure? I mean, once I get on blood pressure pills, well, when can I stop the blood pressure pills? When will you be able to tell me I'm cured? Guess what? Forget it. What about degenerative arthritis? I have arthritis. My back hurts, my neck hurts, my hips. I don't like getting up in the morning. When will that be cured? I take pills for it that helps the pain, but when will I be cured? When? If I have coronary artery disease and I'm now on statins and I'm on a low, tell me when I'm going to be cured from my coronary artery disease. So I don't know why there's this insistence on that when 80% of the disorders associated with maturity aren't curable. You just manage it.
Right. And I think it's a good reminder. Your question of how are you feeling? I mean, if you're feeling well, if you're feeling good and strong, this is something to focus on. And as you say in the garden talk, instead of us asking during breaks, what's your IgM, what's your IgM, and comparing notes on a meaningless number, because all of us respond so differently, because the disease presents differently in our body. It's not connected to a number that we all have a trajectory that follows the same path, but we all manifest it so differently. That's just a good wake-up call. You know, how are we to focus rather on what we're feeling versus what our blood work is saying about us that might make us feel anxious or stressed unnecessarily.
You know, I do now, since COVID, probably 25% of all of my consults now are video consultations. They're remote consultations. And usually I start out by asking people, you know, what was the kind of evolution that leads them up to having the video consult. And usually I just get a litany of hemoglobins and IgMs and viscosities and bone marrows. And I sit and listen for 15 minutes before you go, how are you feeling? How are you feeling? Are you sick? I mean, because my job is actually to make people not be sick, you know, and instead of finding out if they're sick or unwell or this or that, I get a Excel spreadsheet over video.
Wow. Wow. That says it all. That says it all. Wow. Okay, I have two specific questions here that are very support group leader related and Mayo related. And then we're going to be wrapping up and see if there might be some in the chat that we can address. Dr. Gertz, I want to be sure we stick to our time though and get you out of here when we promised. So, because we're so grateful for every minute. Might different patient profiles suggest a preference for seeking a second opinion at Mayo versus other centers? So just some background, the most downloaded item on the IWMF website, I believe, is the physician directory. I know as a Lifeline volunteer, I'm getting a lot of calls from WMers everywhere, giving them that physician, you know, the center, having them, you know, contact. That's one of the first things we do. Anything that we should be thinking about when we're directing people to different centers?
I think the main thing is experience. I mean, there's nothing else to say. And if the center you're talking about has experienced people, you're good to go. And once again, I've used this metaphor in my talk about where I bring my car for repairs. And that is, there are many superb general automobile mechanic that are out there and can do just a spectacular job. But now with my car, which is a foreign import, and it's got 17 computer chips, when things go, I actually go to the dealer, because that dealer only deals with my make of car. And they don't deal with, you know, there's hundreds of cars out there and they can do a general great job. I just want them to have experience with my car. I want that. What I want to hear from my dealer is, oh, I've seen this before 50 times. I will take care of it. Not, could you wait here a minute? I'm going to go read the manual and see what maybe is wrong with your car, and it'll guide me, which is the same thing as saying, wait here, I'm going to go look it up to date and I'll come back with my recommendations. So at the end of the day, if you have someone that has experience and you're comfortable with them, there's not one or two centers you have to go to, but you just like someone who kind of does it, you know, and has a little bit of experience with it, you know. I mean, I don't understand, and this is certainly why someone, you know, would go for a surgical opinion and the surgeon says, I can do that surgery. It'd be my first time, never done it before, but I will do it. And people would walk out, but you go to someone and they have no experience with your disease and they just like, yeah, I'm good.
Yeah. And the factor, the being close to home, or the someone they trust, or they don't want to insult them, talking people down from those trees is such an important part of what we do. That I'll hurt their feelings, or I've known them my whole life, putting your care first.
It's your life. It is your life. So I'm willing to drive that little extra distance to get to the car dealer, and I care a lot more about my health than my car.
Okay, so let's drill down on this if you don't mind. And I want to ask you a specific question. As support group leaders, we talk with a lot of folks who are being encouraged to get second opinions. I'm curious, two-part question. Number one, is Mayo Clinic still seeing out-of-state patients doing telemedicine through video?
Sure. That's here to stay. That's never going to go away. That was a paradigm change with COVID. And right now, we don't have issues about out of state. Now, I can't write you a prescription for medicines if you're in South Carolina because I'm not licensed there, but the ability to do consultations pending a change in federal policy still goes.
Okay, that's really helpful because the out of state issue has come up with other centers, and we are constantly giving folks contact information. So it's good for us to know that they can, no matter where we are, they're being treated by their local person, but they need some help with a treatment decision or a crisis, and they can reach out to you. So here's the second part, which gets a little bit trickier. A lot of times, we get either in our support groups or in between support group meetings, very sick patients who need help right away. And we need to kind of tell them, you need to get to a center of excellence. You need that consultation now. How do they do that at the Mayo? Do you want to give us any logistical ideas of
challenging? That can be challenging because we're all packed with appointments. And so that's kind of a clue saying, don't wait till you're an extremist before you start asking for opinion. Asking for an opinion when things are all falling apart, no offense, it's late, asking for an opinion after the first surgery failed is not a good time. It's probably better to ask preoperatively for that second opinion. And so, we can't guarantee that critically ill patients are going to be able to access, capacity is variable, and so, because of the nature of our practice, we have more appointments in December in Minnesota than we do in July. That's just a fact. Because 80% is in person and people don't want to come to Minnesota in December. So we do have some seasonality to the practice, but at the end of the day, you call, we'll do the best that we can. But if you call and say it's urgent, I need to be seen within 48 hours, it's likely we're going to say you're going to have to go to your local ER. I'm sorry. Next time, call 2 months earlier. People decide on their second opinion when everything's crumbling. That's not ideal.
Yeah, exactly. So we have on the physician directory the contact information for Mayo. Is there anything that you want to give us in terms of how we should best reach out, or do you want to? Maybe I could get that from you, and I can send it out to the support group leaders in writing.
Well, let me just be sure that my number matches your number. First of all, the hematology call center that really triages all the Waldenstrom's calls is 507-284-5096. So that's the hematology call center at Mayo. And so that's the most direct way to request an appointment. And that's about the best I'm going to be able to do. Obviously, if it's that urgent, then you have your doctor call me. And I'll talk to your doctor, and I can give some maybe cursory advice out of the context of a complete. But if it's that urgent, have your doctor call. And if you're in trouble and your doctor won't call, you really need another doctor.
Yeah, exactly. That's critical. Okay.
That's the same thing with the hurt feelings. If someone says, I don't want to, my doctor will have hurt feelings, or will say, if you go to Mayo Clinic, I won't see you again. That's probably a good time to call it quits. That's really immature behavior when someone's dealing with their health. And I just think it's unconscionable.
Exactly, exactly. My dad was a physician for 60 years, and one of my favorite lines of his was, if anybody ever tells you not to get a second opinion, run like the wind as quickly away from that office.
I think that's actually good advice. I mean, there's only one of two possibilities. One is your doctor's doing a great job, or we really suggest modifications, which probably is a good thing you got the opinion.
Right. Well, thank you. That was amazing. Now we have a final question here before we open up a little bit and see if we might have a little bit of time to hear from folks. But this is a question that we ask of all of our WM experts, our rock stars. What is the one thing that you wish every WMer knew today? You can take a moment. We'll play the Jeopardy music, but what's the one thing that you wish every WMer knew today?
That symptoms are much more important than numbers.
Huh, I love it. I love it. I'm writing down.
I know, and I want you to know that I bet everything on that.
Yes.
It was
Wow.
a true double Jeopardy.
Dr. Gertz, such an absolute joy. Let me see, before we let you race back to your day, are there questions in the chat, or do folks want to know? Okay, we're good. It's 12:32, and I want to be sure. Dr. Gertz, do you have a couple of more minutes to hear the voices of folks around?
Sure,
or are
that'd
you
be
having
okay.
to run
No,
off?
I think I'm doing okay.
Oh, thank you kindly, because we're just going to be wrapping up soon. But maybe just a couple of questions. If people had something that's, again, general enough, we're not talking about specific treatment things or anything personally medical.
Don't worry, I'm not giving you a management opinion on the phone.
I don't have to worry about that. Okay. And just a friendly reminder from Amazing Shelley that if you are unmuting yourself and speaking, please remember that you will be recorded, because this link is going to be shared. So just be comfortable with that. Oh, Marcia, I hope you're going to ask a question, my friend.
Oh, gosh.
Well, did you unmute?
I love your comment, Dr. Gertz, about focusing on symptoms rather than numbers. And I think that's so important. I've had high IgM for the past 20 years, my lowest probably in the 2000 range, but, and we never really focused on getting the treatment down to a certain IgM level, but just feeling okay and being able to have a good quality of life was the biggest issue. And also the emphasis on clinical trials. I was in 8 clinical trials, and I can say that they helped me to keep going with a good quality of life. And at the same time, it did contribute to research, of course, but it was mainly to keep the disease in check for a long period of time. Thank you.
Marcia, I'm so glad you spoke up, because when Dr. Gertz was talking about the clinical trial, I totally wanted to reference you as just like, with pride, 8 clinical trials. I'd like to see anybody match that. Marcia, you've done an enormous amount for research and for the IWMF support group, leading the support groups nationwide. So thank you for everything that you do.
Thank you, Lisa.
Such a treat. Let's see, anybody else before we wrap up here? I hear someone.
Me, Lisa, Cindy.
Cindy, great. Oregon.
I ask if it is possible, can you test for MYD88 and CXCR4 by way of a blood test, or do you think that only a bone marrow biopsy will do it? I know you said you have to have the IgM cells in there, so maybe that is a factor.
So you can test the peripheral blood, because you actually, in patients with active Waldenstrom, there are actually circulating cells in the bloodstream that you can pick up, but the sensitivity is lower than the bone marrow. So if you come up negative, you're not 100% sure. And the same thing applies if you're on treatment. That really lowers the likelihood that you're going to get an informative study. It would be wrong to say that the blood is not a source. If it's positive, I'm sorry, if it's mutated, then the blood it can be used, but it really isn't as good as the bone marrow. And I don't find that it is preferred to the marrow.
Thank you.
Wonderful. Dr. Gertz, is there anything that we as support group leaders can do to make your job easier? Anything at all that we can communicate to groups or, you know, kind of shout from the mountaintop?
Yeah, I think I led off. I think my introductory comments in the first 15 minutes, I think focused on what support group leaders can do to help guide patients to optimize their care.
Fantastic. Fantastic. I want to thank you wholeheartedly for such a fabulous conversation. Thank you for spending this time with us today. I learned so much. I know we all did. And we're really, truly so grateful for all that you do every single day, Dr. Gertz, for your invaluable work of the hands and your heart on behalf of WMers trying to improve our lives, all of us across the world. We are so thankful, and I hope you feel that gratitude. And we all just want to give you a huge round of applause and tell you to keep on doing what you're doing. We could not be more grateful.
Lisa,
Thank you.
You bet. I just so you know, I did actually come with jokes, but decided I'm going to save it for when we go live.
No.
Yeah, I don't think it'll have the same impact on Zoom. So I'm just going to keep it to myself.
I respect that. I respect that.
All right.
Thank
You guys have a
Doctor.
great weekend.
Thank you
Bye-bye now.
so much. We're
Bye.
really grateful. Bye-bye.
Bye.
Thank you, Dr. Gertz.
Wow.
Wow.
Wow.